diabetes. Sorry. Could ask me to speak about diabetes at the nursing station. And so I got a lot of questions about diabetes, and I thought we'd sort of hit on some of the frequently asked questions so that we can go through, get some.
Okay.
There we go. So hopefully we can go through some of the, I'm going to call them frequently asked questions while we go through sort of everything about diabetes. I'm going to try to keep that into 40 minutes or so. So there's a lot of time for questions if there's anything else that we haven't hit on. Okay, so here we go. So the objectives, things I want to go over today, I'd like to go through a complete diabetes visit and to start to provide an evidence-based approach to basically all aspects or most aspects of diabetes management. And then while we're doing that, as we go through, we'll talk about some of the frequently asked questions and questions that I get very often by e-consult or email and things like that. The one caveat, virtually everything I speak about today relates to type 2 diabetes. Some of it's similar, but a lot of the stuff is very different for type 1 diabetes. So I thought that was a less common population. So I actually left that on the side a little bit. Okay, so the comprehensive diabetes visit, or the complete diabetes visit, I think it's very important for everybody who provides care for diabetes to have somewhere in their head or on paper a complete approach to diabetes. And it's not because every single visit is going to be a comprehensive or a complete visit. It's more so that we don't miss things in the future. At every visit, we should be choosing priorities with the patient who's in front of us. And sometimes your priorities will be identical to the patient's priorities, and sometimes they'll be different. But it's important to have an idea of what we're focusing on. The reason it's good to have a very complete approach is that if you're always focusing on the same things, you may never get to other things. And for me, that happened a few years ago where I noticed that there's a couple of things that sort of always got missed, and that was foot examination. And when I was a fellow, I was training, and I never remembered to do the foot exam. I always deferred that because they were wearing winter boots or something else. So it's important to have a complete approach in your head so that you make sure that you don't miss things in the future. So what are the aspects of a complete diabetes visit? Well, I consider them to fall into 5 categories in general. The first 4 apply to everybody. The 5th one is only for some people. And the first aspect is lifestyle management and what people do with their lives. Then there's glycemic management, vascular risk factors, complications, and then some special considerations, which I won't go into detail today because they are special considerations specific to each particular patient. When I talk about that, I talk about things like, is pregnancy a special consideration, or do they happen to have cirrhosis or something else? So the first aspect is lifestyle, and for lifestyle, we usually talk about diet and exercise. It's often a missed piece of our approach because we're busy or we're focusing on not considering this to be a very strong thing, something that we can improve the numbers by a lot. But it's very, very important, and it is actually quite a strong predictor of decreasing complications and things in the future. So this is something that we got to be very focused on, and we should be talking about probably at almost every visit. So what do we talk about when we talk about lifestyles? So physical activity, the Diabetes Canada guidelines give us some recommendations about what we should do for physical activity. I don't particularly like how they're written, and what they write is 150 minutes a week of moderate to vigorous physical activity, some kind of resistance activity 2 to 3 times a week, and reduce sedentary time. The only part of that I like is the last sentence. And the reason I don't really like this is because when we talk to our patients who are very sedentary or have a lot of mobility issues and things like that, telling them to get 2.5 hours of moderate to vigorous physical activity is not a really good way of making people more active or making them happy. It's just an extra piece of work for them to do, and a goal that they feel they can't achieve. So I I have that goal in my head that we're going to try to get there because that's the amount that has been shown to be protective. But really, I say any activity is better than no activity. And so you work with your patient and you find out what they like to do. That's probably the most important thing. If they like to go for evening walks, that's fantastic. Start with an evening walk, 3, 4, 5 times a week, 10, 15 minutes, and slowly work your way up from there. If somebody has mobility issues or an amputation, they might feel this is very difficult, but there still might be some things they can do and they still like doing. So work with your patient. Any activity is better than no activity, and try to work your way up to 2 or 3 hours a week total. What do I mean by moderate to vigorous physical activity? I usually tell people you should be able to speak. So you shouldn't be so out of breath that you can't say anything, but you shouldn't be able to give a speech. So every 4 or 5 words, you should have to take a breath. That's how active we want you to be. That's what moderate to vigorous physical activity essentially means. Diet, this is another one that's very important, and some of you may be dietitians or work with dietitians. This is probably one of the most difficult parts of diabetes management because there is no quick fix diet, and people are very attached to the types of foods they eat, and budgetary considerations have a huge impact on what people will eat. So what I like to work with what people can afford and what they eat already. The target is to reduce calories and decrease simple carbohydrates with an increase in fiber. Try to avoid fad diets. So what do I mean by less simple carbohydrates? That essentially means if you can, try to decrease the amount of rice or noodles or pasta or potatoes, and then substitute in things that are a little bit more complex. So if it's someone who eats a lot of white rice, maybe you can switch over to a brown rice or a wild rice, or have just a little bit less of it, those types of things, and try to work with what they have, increase the amount of fiber and protein in their starches, and then also just decrease it. So instead of having a sandwich with 2 pieces of bread, have a sandwich with 1 piece of bread, eat it open, and that might be a little bit better. Fad diets have been shown to be very effective at losing weight and improving things, and very difficult to maintain. And so if somebody comes and tells you, I really want to try the keto diet, and they decide to cut out all their carbohydrates, quite often they'll do really well for a month or 2 and then gain all their weight back. And there's kind of a step backwards when that happens. You can decrease A1Cs up to 2% just by fixing diet. Quite often, actually, I've gotten a lot more than that in some situations as well. A lot of us, those of us who aren't dietitians, we aren't experts in this. So I don't consider myself an expert in diet. So I think accessing a dietitian whenever possible, if you have one around, is very important. The other parts of lifestyle, weight loss, 5%. It doesn't have to be big. Someone who's 220 pounds who wants to get 150 pounds, try to change the goal, try to get 5 or 10 pounds off, and work on their lifestyle, because they'll feel like this is success. And then you add another 5 or 10 pounds. So it's important to be motivating people and to try to get them succeeding at the goals that we're setting. Smoking is a strong risk factor for all vascular complications. So whenever you can, addressing smoking status is important. So then the next part is glycemic control. So then the question is, and the question comes quite often, how much does glycemic control matter? This, I'm going to show you some data actually for a second. And this is some data that we have from an old trial, DCCT trial, where it shows, well, if the A1C is this, what's your risk of getting a complication? And the red line, the retinopathy, so eye disease, is the strongest sort of link with glycemic control. And you can see that even as the A1C goes from 6 to 7 to 8, it's slowly increasing. And that really is quite exponential in its shape. And so from 8 to 9, there's a big difference. From 9 to 10, even bigger, and from 10 to 11, even bigger. So every percentage point is not created equal. It's not the same getting from 12 to 11 as it is getting from 10 to 9. As you get lower, you've got most of your benefit behind you. And the reason this is important is because some people ask me, does it really matter if someone's A1C is 8% or 7%? And I say, well, if you look at this chart, it's not a huge difference between those two. When you got them from 12 to 8, that is a huge success. From 8 to 6, that's a tiny success. So don't feel like a failure, and it's important to encourage people when they get down into these ranges that we're trying to get better or lower A1Cs, but it's not as important as what we've already put behind us. This I'm going to skip. I'll come back to this one in a second because there's this one. And the next question that people have is, how fast should I get to the target? This is a very busy figure, so I'm going to walk you through just a short little bit of it. In this paper, they looked at people's A1Cs and how long they kept that A1C and what their complication rate was in the future. So this chart is dealing with the complication of mortality, so death specifically. And if you look at just these bottom 4 bars, the very bottom bar of that circle is people who for the first year, 0 to 1, so for the first year, they had an A1C that was average 6.5 to 7%. And the square, it's 7 to 8, and then 8 to 9, and then it's people who are over 9. So those are the things. And that's, they basically, if for the first year they have different A1Cs, it doesn't affect their mortality very much. In the second year, if for 2 years you have a lower A1C versus a slightly higher one and higher, you start to see that the higher A1Cs, people have a higher mortality. And there is actually a separation within 3 or 4 years. So if you, for the first 3 or 4 years, you have a better A1C versus someone else, in long term, it will predict less mortality. Now on that first one, so those aren't very different. And it takes 6 or 7 years before you really see a lot of separation in here to see that that risk is there. But in that first slide, this one shows complication rates. And on the left, you can see microvascular complications, and you can see a huge separation even at 1 year or 2 years or 3 years. So if for the first 3 years you have a low A1C versus you have a high A1C, there's a gigantic difference in who's going to get microvascular complications. So very early on exposure to a high A1C does predict complications for microvascular disease and for macrovascular disease, not as much, but it is there. And for mortality, takes a little bit longer before the mortality gets there. So how fast should we get to the target? Well, we should get there fairly fast if we can. Once somebody is working with us, we should try to get down to our A1C target as quickly as possible. So what is the A1C target? It's not the same for everybody. We were trained for a lot of time to pick 7% or lower for almost everybody. There are some people we can get down to 6.5%, and the lower you go, the better it is, especially for eye disease or for kidney disease. And so those two things, if you can get there without getting a lot of hypoglycemia, we would suggest trying to get down there. But for some people, it is completely appropriate to choose a higher A1C. So I always have in my mind for each individual person I see, what's the A1C I'm going for? Is it 8% for this person because they have limited life expectancy, or even 8.5% if they have dementia or something like that? And so what are the situations in which I pick a higher A1C versus a lower one? If it's somebody who's 20 years old who already has retinopathy, I will try as hard as I can to get that A1C as low as I can, because there might be 60 or 70 years left to try to protect those eyes. And so this is an important thing to know, that it's not a one size fits all. We used to say 7% for almost everybody, but now we've got some ideas that there are some people who should be higher, and there are some situations in which we can try to go lower. So what do we use for anti-hyperglycemic agents? So it's a very individualized decision. There's no, even though at the end I'm going to tell you there's a bit of a one size fits all, I'm going to say right now, there's not really a one size fits all. You have to take into consideration things like cost, coverage, the side effects, what their renal function is doing, their weight, things like this. So these are the important things to look at, and weighing these pros and cons of each agent when you're choosing what you're going to be using. So for each one of the classes, there's more than 6 classes of medication. I'm going to go through them one by one. I'll spend a little bit less time on the older things, a little bit more times on the newer things to get more questions about that. And I think those are the questions that people are interested in. But we'll go through the considerations why you would and wouldn't choose things one by one for these guys. So the first one we'll talk about is metformin. Metformin is the first choice for virtually everyone. The reason for this is it's very old, it's very safe, and it works very well. And we have a trial that shows that it's has benefits above and beyond what it does for sugar. So that's one of the reasons I use it as first choice for almost everyone. On top of that, the newer trials and the newer medications, we actually studied them in addition to metformin. So when we start talking about the newer stuff, the SGLT2 inhibitors weren't studied by themselves so much. They were studied more as an addition to metformin. So this is a base for most people, and then we add other things on top. Very cheap medication for people who have no coverage, $2.50 a month at the target dose of 1,000 milligrams twice a day. I consider there to be really only one dose for metformin, and that is 1,000 milligrams twice a day, unless you have to change it for the renal function, so or side effects. So I don't really use the lower doses, and then as the A1C goes up, then increase the dose. I try to get everybody onto the maximum dose unless there's a reason to decrease it. Key things to remember about the GFR, decreasing things as the renal function decreases. And I generally will tell people stop it when it gets to 30 or so. There are a few people we keep on a little bit longer than that, but usually at about 30, we'd say stop the medication. It is very strong as a medication. I think probably everyone here has seen somebody show up with an A1C of 15%, do some diet and some metformin, and you get 4 or 5% off their A1C. But usually say 1 to 3% you can get with just metformin. The side effects are those GI side effects. A very important thing to know, it is safe in pregnancy. So we're using it quite a lot in our pregnancy population now. So metformin, everyone's sort of familiar with that medication. It's a very good thing to use. Second medication, the sulfonylureas, used to be our second choice medication. Now we don't use it very much at all. And one of the reasons is because we've got so many newer things that don't have the same risks as sulfonylureas. But people are comfortable with them, so we use them. We sometimes still default to them as our second choice. They're very cheap, same thing, $3 a month or so. And so if cost is a consideration, this is a good medication to choose as well. I don't believe there is any situation in which a sulfonylurea should be used except for glycoside MR. The risks, if you go to the bottom of hypoglycemia, especially, the hypoglycemia risk is lower with glycoside MR than it is with any other sulfonylurea. So if you have a patient on GLPIR, it should be switched to glycoside MR. If you have a patient on glycoside usual, it should be switched to MR. There's only one sulfonylurea in my head, and that is glycoside MR. So if you have to use it, that's the one that I would suggest. It is very strong when you start people on it, when they just got their diabetes diagnosis, and it's quite weak 20 and 30 years later. But for some people, it becomes weak over 2 or 3 years, and some people it takes 10 or 15 years before it becomes weak. So you don't really know what kind of effect you're going to get usually when you're starting the medication. But this is the sulfonylureas, which I think most of us will be familiar with. The newer agents, the DPP-4 inhibitors, so these are the things that end in gliptin. So there's sitagliptin, linagliptin, saxagliptin, alogliptin. Those are the 4 that we have. Their brand names are things like Januvia, Tradjenta, and Onglyza. These medications, very few side effects, extremely well tolerated. And so they're really good for that reason for people who are older, who have lots of other medications and things like that. It's really hard to overdose on them. So people who have cognitive impairments and you're not sure about their medication administration, things like that, they're not a very risky medication that way either. They are expensive, $85 a month. They have good coverage, however. The dosing, in my head, you really need to remember 2 DPP-4 inhibitors, sitagliptin and Januvia, 100 milligrams a day for almost everybody. Linagliptin, that's Tradjenta, 5 milligrams a day. And actually, as the renal function declines, you don't even need to change the Tradjenta dose. And so that one is a good one that if somebody's getting a renal issue, you can put them on Tradjenta 5 milligrams, set it and forget it kind of a thing. The sitagliptin should be adjusted as the GFR declines. It's not a very risky medication if you accidentally leave them on the bigger dose for a while. But yeah, this is one that should actually be decreased as the GFR declines. They're not very strong medications, but the real key for this medication is they have almost zero side effects. I noticed something in the chat here. I think this is about metformin. So a question about helping people to better tolerate besides going very, very slow with dose and increases. Do you think the risks are really high enough to justify passing this medication by, given the added cost to our healthcare system? Okay, that's a very detailed question. For the metformin question, the metformin, to get people to better tolerate metformin, going slow is one way. The other way to do it is to use the extended release metformin, and the extended release metformin is not covered, but does have slightly lower risk of side effects. It is covered in only one situation, and that is when you use it in combination with a DPP-4 inhibitor, Januvia. So there's Januvia with metformin extended release. That's called Janumet XR. Janumet XR is covered. It's the only version of metformin extended release which is covered. So if you would like, if somebody has side effects, that's the way to go for getting them onto the extended release metformin. Otherwise, it is really going very, very slow or picking a lower dosage. The risks of this is going to be about sulfonylureas. Are they high enough to justify passing over this medication? I think they are, and that's because of the benefits that we're going to show for the other medications and the risks and the cost of hypoglycemia. So as weight goes up and as hypoglycemia frequency goes up, there's also an added cost to the healthcare system. Okay, so the next class of medications is the SGLT2 inhibitors. So this is one that we hear about a lot now. These are things that end in gliflozin. So there are 3 of them: canagliflozin, dapagliflozin, and empagliflozin. Their brand names are Invokana, Forxiga, and Jardiance. They have a lot, they have a handful of side effects. They're definitely more than the DPP-4 inhibitors, but they're relatively common in people. They have excellent vascular protection. So this is the first class of medication that doesn't just decrease sugars. It decreases sugars and improves heart disease and kidney disease above and beyond what it does for sugars. So there's a little bit extra benefit you're getting from these medications beyond just what it's doing for the sugars. Same cost as the DPP-4 inhibitors, same coverage virtually across the board. So if you have coverage, this will likely be covered. The dosing, I would suggest only remembering 1 dose for each of these, because there are 2 doses for each one, and they work almost identically in terms of GFR and A1C lowering and their vascular protection. So if you can remember 110 or 10, 1 dose for all of them across the board. Renal function, you actually, at first we said only use them in the higher renal function because that's how they're studying, but if the GFR is over 30, you can't really use them, and you can continue it down to dialysis. So that's the newer information that we have. So there's, it's very renal protective actually in these cases. It's fairly weak as a medication, and the lower the GFR goes, the less A1C reduction you get. So this is an important thing to know as well, that if somebody has a GFR of 35 and you add canagliflozin, you're not going to get very much for their A1C. You're doing it for kidney protection in that case. The side effects are yeast infection. So there's actually not very much increase in the risk of urinary tract infections, just bacterial urinary tract infections. It's really yeast infections that's the big risk. Usually within the first couple of months of starting it, you can treat the yeast infection exactly how you would usually. So Canesten, fluconazole, those types of things. You could hold the medication until it clears up and then restart it. The risk is higher in women, just as it is usually. It can go up to 10–20% in women who are on this medication. For men, they're not usually used to having yeast infections.
Yeah, I wanted to get on here to get to this here. I'm struggling with my foot.
The other benefits of this medication would be loss, and then also improves a little bit. So you get 3 or 4 points off the blood pressure and 3 or 5 pounds off the weight as well when you start this medication. So from a vascular protective standpoint, there is really robust evidence. There's a lot of good clinical trials now for people who are at high risk for heart disease, heart failure, or kidney disease, and they show a lot of benefit with SGLT2 inhibitors. It seems to be consistent regardless of which one of them you choose. There are slight differences in who's studied, or which agent was studied in which population and which different population there were. In general, in my reading of the evidence, they're all very good and they all seem to have the same benefits, but there is a difference, and I'll tell you about the differences in a second. So we get things like there's 35% reduction in things like heart failure, kidney disease, cardiovascular death using different agents in different populations. So there's quite a robust evidence base for these, for the vascular protection as well. And like I said, how do you actually choose one? Different clinical trials for each one. And so you might look at the patient and say, well, they fit a specific clinical trial a little bit better than they fit something else, and I'll choose an agent based on that. But they really are, kidney disease, canagliflozin and dapagliflozin were studied. EMPA, we're not going to have the answers for a couple of years. Heart failure, DAPA and EMPA were studied. Cardiovascular disease, CANA and EMPA have better evidence. So there's really a difference across the board, but you can see that there's 2 of the 3 agents in any given population, but our patients are often 2 of these 3 patients, or even 3 of 3 for some of them. And so you could really get away with choosing whichever one you want. If you have a specific compelling indication, you might pick one specifically, but in general, I tell people that you can use them fairly interchangeably. Questions that people ask me a lot about SGLT2 inhibitors: amputation risk. So there was a trial with canagliflozin, which showed an increase in amputations. And subsequently, there's been a lot of data and a lot of study looking at what is that amputation risk. It hasn't shown up again. So there was one trial in which it showed up. It was there. It was a fairly low risk overall. But then when they did the studies in even higher risk populations, it didn't show up. So then the question is, was it just a fluke that it showed up in that one study that one time? Well, there's some other real world evidence that suggests that there is a slight increase with all SGLT2 inhibitors for amputations, and there's other evidence that shows that there's not. And so what I usually recommend to people is that it's a very small increase if it exists. If it exists, it's probably all of them. And so I would not avoid an SGLT2 inhibitor in somebody who has an amputation in the past. If somebody has an at-risk foot, I would suggest getting foot care involved as well, because the amputations seem to show up in places where they don't have good foot care as well. So if that's a concern, maybe I would stay away from this medication until there's some good foot care happening as well. The other question is, should you be concerned about euglycemic DKA? So this was a risk that showed up where people can get DKA without getting a high sugar when they get put on SGLT2 inhibitors. The risk is quite small overall. It's probably 1 in 1,000 or so. Most of the risk is when we accidentally or on purpose originally give it to people who have type 1 diabetes. And so what I would recommend is that we never use these medications in someone you know has type 1 diabetes. And the second thing would be, if somebody gets DKA on an SGLT2 inhibitor, I would not suggest starting it again. I would stop it in that situation and suggest not starting it again without talking about it with an endocrinologist or something like that. You want to figure out whether the patient has type 1 diabetes or not, and whether there were other triggers involved. I will sometimes use them again, only in the setting of other triggers, and usually if they're on insulin. So insulin can be protective against this as well. So if somebody's off of insulin and they get this, I wouldn't restart it unless they're now on insulin. The next medication are the GLP-1 receptor agonists. These are very strong medications. They have that vascular protection that we talked about in the last group. They're very expensive medications, and they do have a lot of side effects. People are uncomfortable with this medication quite often, but then very happy if they work. So the cost out of pocket, something like $200 a month, $200, $250, depending on the pharmacy. The dosing, I only put semaglutide, that's Ozempic's dosing up here. And you're trying to get to 0.5 or 1 milligram a week. And I'll tell you why I only put one of them up here in a second. Renal function, you can use it down possibly down to dialysis, although it's not really quite, there's not a lot of experience with that, but you can use it definitely up to a GFR of about 15 or 30. Glycemic benefit, you can get a lot of percentage points off with this medication as well. So it's a really good medication for getting people off of insulin, for instance. The side effect is nausea. So semaglutide is once a week. The nausea usually happens within a couple of days of the injection. So if you take the injection on a Sunday, Monday, Tuesday, there'll be some nausea. Usually Wednesday, Thursday, Friday, you're fine. The next week, it happens again. That week after that, it's a little bit less and less. So usually the first 2 or 3 weeks is when it happens. And then it goes down and down after that. By the 4th and 5th week, it should be gone for most people. That's when you increase the dose. Every time you increase the dose, it comes back for 2 or 3 weeks, for 2 or 3 days of those weeks. So just after the injection for a couple of days, and then it fades away for the end of the week. It does also increase heart rate. So don't be surprised if you see someone who has a resting heart rate of 70 become a resting heart rate of 80, or if someone was just under 100, you might notice it's going over 100. So we might need to titrate some other medications because of that. There's substantial weight loss benefit, around 5 pounds for most people. The higher you go on the dose, the more you get. It has the same blood pressure benefit actually as the SGLT2 inhibitors. We don't talk about it a lot, but you do get 3 or 4 points off of the blood pressure as well. How do you actually choose a GLP-1 receptor agonist? Different trials had different results for vascular protection. The cost and coverage is also very different. So we want to look at those pieces of information. And what it turns out is the vascular benefit shows up in 3 of them, but there's only 1 of them that's covered. And so I usually say semaglutide is the one to use. It is also slightly more effective for weight loss in A1C, and it has vascular protection as well. So because this is the covered version, I suggest people, if you're going to be using a GLP-1 receptor agonist, you should probably be using semaglutide at this point. The dosing, this is what I was saying earlier, 0.25 to start with. 4 weeks later, you can go up on the dose. Usually they'll get their side effects back, then they fade away. If it's not enough at that point, you can go to 1 milligram. It costs the same. The coverage is the same. It just comes in a different pen. And then you can get a little bit extra A1C benefit as well. These are the questions I get about GLP-1 receptor agonists the most. The first one is pancreatitis and pancreatic cancer. It causes an increase in the lipase without a substantial increase in clinical pancreatitis. So anybody who comes with pancreatitis to hospital and they're on one of these medications, I search hard for another reason for their pancreatitis. If no other reason can be found, I am willing to try again at least 6 to 12 months later, 1 time. If they get pancreatitis a second time on this medication, then I will, and there's no other cause found. There's no gallstones or other medication or trauma or surgery or something. If there's no other reason for it and they get it twice, then I'll say they probably shouldn't be on this medication again. It's quite a low risk if it exists, low enough that it's a question that whether it exists or not. Pancreatic cancer, same thing, doesn't seem to show up. There was a concern when the medication came out that it might cause pancreatic cancer. In all the research since then, it has not shown an increase in pancreatic cancer. The original research was a little bit flawed, actually. And so I do not consider pancreatic cancer to be a risk with this medication. Risk if a patient has retinopathy. There is a risk if a patient has retinopathy, and the risk came in one trial where they showed an increase in sight-threatening retinopathy. When you look at that trial, the issue actually is, and this is an important thing to know, is that people who have retinopathy, whose A1Cs drop fast, will get worsening retinopathy, and they can get bleeds in their eyes from that perspective if that happens. This is true of any way that you drop somebody's sugars, but there are only really 2 ways in which this can come up. Ozempic is very fast at lowering people's sugars. And so if you have somebody with an A1C of 11%, you put them on Ozempic and their A1C goes down to 7% 2 or 3 months later, and they had retinopathy that wasn't treated, that's the person who's at risk of getting a bleed and having sight-threatening retinopathy. It's also true in insulin. So you can use insulin to bring people's sugars down a lot. We do it in pregnancy, and that's where this research actually originally came from. If you lower the A1C very fast in early pregnancy, people can get blindness and retinopathy problems. So the people to be concerned about are the people who you haven't screened them for retinopathy at all. You don't know what's going on in their eyes, and their A1C is high. If they're being treated for the retinopathy, if they have lasers or they have injections, I think that's actually protective. So then you could go for it. But if you don't know what's going on with their A1C or with their eyes, and their A1C is high, and you're pretty convinced that they're going to have some eye problems in there, make sure they're seen by an eye doctor first, and maybe go a little bit slower with the Ozempic titration. Thyroid cancer, the thyroid cancer is not really a concern. There is a black box warning about medullary thyroid cancer, which is the rarer of the two types of thyroid cancer. It turns out that in rats, it does increase your risk of thyroid cancer. Rats are obviously different from humans. They have a GLP-1 receptor agonist, or GLP-1 receptor on their medullary, their C cells in their thyroid, and that's why it shows up there. The problem is because it showed up in rats, everybody ever with medullary thyroid cancer is excluded from every single human trial. There is no real mechanism by which this could be a concern, but it is on the side, just the thing to know, the side of the box. The thing to know about it, it's not the usual type of thyroid cancer. It's a whole different, rarer type of thyroid cancer. So if your patient has papillary thyroid cancer, GLP-1 receptor agonists are not a concern. I'll check the chat for a second. Yeast infection is going to be a general yeast infection for the SGLT2 inhibitors a few slides ago. It will usually be a general yeast infection for that. Would I avoid anyone with a history of DKA for SGLT2 inhibitors? No. If they have, especially if they have DKA on original diagnosis, if they've had DKA in the past and I would give them an SGLT2 inhibitor if they haven't tried it again. If they get DKA again, then I would say the things that I said before. Someone has a history of pancreatitis. Yes, all right. So that was the one I was getting at. So if they have pancreatitis and you have a different reason for it, I would use it. So if they have gallstone pancreatitis, traumatic pancreatitis, doesn't matter what the reason is. If they've had pancreatitis and if they have a clear reason for it, they could have had pancreatitis 4 or 5 times in the past, and I would consider this a safe medication to use. Insulin. So a lot of people are on insulin, but I usually try now to avoid insulin at all costs. Can get very expensive. We don't consider it to be a cheap an expensive medication, but it can be, depends on what the doses are really. I only suggest once daily insulin for almost everybody. Usually we don't need rapid insulin. There are patients obviously in which that's not true. Be a little bit slower with the titration as the GFR goes down. It's safe, but it lasts a little bit longer as the GFR declines, and so that's a consideration there. Glycemic benefits infinite. I can turn any sugar into any other sugar using insulin. So if someone's A1C is 20%, it can come down to 7. We just need to find the right doses. So there is no limit to how strong or weak insulin can be. The side effects, definitely weight gain, definitely hypoglycemia. Weight gain is a big problem because as people gain weight, they need more insulin. And as they need more insulin, they gain more weight. So this is a cycle that happens quite a bit. I suggest usually using only Toujeo or Tresiba. They're both covered and they have less hypoglycemia than the others. Basaglar is the cheapest of them though per unit cost. So if cost is a concern, that would be the issue to use. Titrate 1 to 2 units every couple of days to get the target dose glucose down to 5 to 8. Try to engage patients in their own self-titration. It's something they can control. So give them some advice about this, and it's a very good thing to do. Maybe they do it a little bit slower if they're afraid of the lows or something like that, but engaging patients in their own self-titration, I think, is important. So if you look through all of the things I said, it's not really one size fits all, but if you wanted to, this would be my approach for almost every patient. Everyone gets metformin. Then if there's a reason to pick one or the other, I'd pick an SGLT2 or a GLP-1, and then I'd pick the other one. And then if it's not working, I'd add gliclazide MR and then basal insulin. And so this is the order that I would suggest people work in for most patients these days. Obviously, there's special considerations like renal function and things that might change things. Who needs to measure their glucose? This is a question I get a lot. The only people who really need to measure their glucose is people who need to know their glucose for their medication purposes. So people on multiple daily injections of insulin, because their fast-acting insulin might be dosed based on their glucose, so they need to measure their glucose. People who are at risk of hypoglycemia need to know how to treat hypoglycemia and to check for hypoglycemia. So those are patients who are on gliclazide or on insulin, and that's about it. Otherwise, we don't really need people to measure their glucose, and that's a piece of work that some people are doing for themselves or because we told them to do it, and it doesn't actually add very much. You can use it if you want to, or if patients really want to test their sugar, that's fine. But people are usually very happy when I tell them that they don't need to measure their sugars 3 and 5 and 7 times a day. Sometimes what I'll get them to do is measure their sugars 2 or 3 times a day, just for the week before they come in to see me. Because I don't need to see their sugars for 3 months, and they don't need to see their sugars for 3 months. But if we have 1 week's worth, that's enough to make some decisions. 1 week's worth plus an A1C, that's usually enough to make our next decision. Vascular risk, statins, ACE inhibitors, antiplatelets. This hasn't changed very much, so I'll go through this fairly quickly. The diabetes guideline has a whole chapter on each of these, and has a little, actually an app online that you can use to see what should people get. Who should get a statin? Almost everybody. Usually it's people who are over 40. So most of our patients, they make it to 40 years old. That's their indication for a statin. But any complication will get you a statin, or if you've had diabetes for 15 years. So some people get diabetes in their early 20s or late teens. Those people would make 15 years before they make it to the age of 40. And so these are the people who should get a statin. Who should get an ACE or an ARB? Anybody who has a complication, so clinical cardiovascular disease, or if you go down microvascular complications, or if they're 55 years old. So it's a little bit longer before they show some benefit with ACEs and ARBs. We should really only be using these 3 agents here because those are the ones that have been tried and shown to have some benefit. So this is important for the ACEs and ARBs. So statin, if you're 40, ACE or ARB, if you make it to 55, or if you get a complication, or if you have high blood pressure. Question I get asked a lot, what should we use second for high blood pressure and diabetes? In a lot of patients, we don't actually have a preference, but in people with diabetes, we do have data to show what should go second. So first is the ACE inhibitor or the ARB. Second is a calcium channel blocker. So there is some data to show that calcium channel blockers are actually better than thiazides. We use thiazides a lot because they come in combinations with ACE inhibitors. So you might choose, I don't know, perindopril and dapamide because they come together. But there are actually combinations of ARBs and calcium channel blockers which are covered, statins and calcium channel blockers which are covered. And so you don't have to pick the thiazide because it's a combination pill to decrease the pill burden. You can use a calcium channel blocker. So usually pick an ACE or an ARB, then add a calcium channel blocker, then add a thiazide. Who should get aspirin? There was a question for a long time about whether we should be using it in people who don't have vascular disease. We now have answers to that question. It doesn't really seem to protect those people. So don't routinely use it just for protection in people who don't already have vascular disease. Anybody who has vascular disease, cardiovascular disease, should be on aspirin, low-dose aspirin. The thing that I used to forget about, so looking at the complications, the feet. So make sure you're examining everyone's foot or feet once a year at least. Look for ulcers, look for pulses, look for sensation. If they're high risk, you might want to do it more often or every single time you see them and involve foot care, whatever resources for foot care you have, nursing, wound care, podiatry. Make sure you give advice around self-care at home because this is also really important. We only see them every once in a while. Things like wearing shoes in the house if they have a lot of neuropathy. This is actually protective. Wear white socks. White socks are good because if there is bleeding on the bottom of your foot, you'll see it when you're taking off your socks. Look at your feet every week. Look through your shoes just before you put on your shoes. Make sure there's not a stone in there and things like that. So these are just all that we can do to improve their foot health. The retinopathy, a lot of people will have availability of remote retinopathy screening. And so you can get the retinal photographs taken and they get examined by an ophthalmologist somewhere else. So access that if you can. Retinopathy screening annually for virtually all patients. There's all these rules about who should start and when they should start. I just say everybody who has diabetes should probably start as soon as they get diabetes and make sure that they're getting it done once a year or so. Retinopathy does not have symptoms for most people. The first symptom of retinopathy may be irreversible blindness. So and it's very preventable with screening. And so it's really important that when people tell us, I never had blurry vision before, the blurry vision is not a symptom of retinopathy, and they could go irreversibly blind, which obviously is a devastating outcome without having any kind of prodromal symptom of any kind. So this is really important that we get the retinopathy screening done. It's still the leading cause of acquired blindness in North America. In Scotland, it is not the leading cause of acquired blindness because they've done a really good job of going around with trucks to all the remote communities and getting the retinopathy screening done. So if you have access to remote retinopathy screening, this is a really good thing to protect people. And then the thing that's really important is keeping it all together. So I said I was going to go through everything, but then you don't have to do everything each time. But having a flow sheet, Diabetes Canada has this flow sheet. I actually have one on my computer that's a little bit different because I don't like how busy this is. Have a flow sheet so that you can put together what you did at each visit and just sort of follow it on a chart. So if you don't see somebody for 6 months or a year or 3 months, you can see what your priorities were last time. You can pick different priorities or the same priorities this time, but then you have an idea of how long it's been since you've done each thing. So this is one you can download it off the Diabetes Canada website, print it off, but then you can actually see as their weight changes, blood pressure, so on and so forth. So I suggest that most people have a flow sheet so that you can see what you've done and what you haven't done, which is important because we don't have the time usually to go through everything each time. So what's the checklist for actually picking medications? Because that's really big. This is all the information you need to know. This is everything you need to know to pick a medication. What's my target for the A1C? Do they have drug coverage? Are there any of these extra compelling indications? Should they be on a statin by age? What's their LDL? Should they be on an ACE inhibitor? Is their blood pressure at target? Should they take an aspirin? That's really it. That's how I choose the medications for every single patient each time. And so you really only have 7 questions to answer. I guess some of these are 2, 10 questions to answer in order to choose the appropriate medications. And I'll leave the last 10 or 15 minutes for questions. I'll check the chat to see if there's anything in there already. Oh, thank you. If anybody has any questions, you feel free to unmute your mic and ask or type into the chat box. Anything to do with diabetes.
Dr. Sidhu, can I just ask you about statins? And do you really care about the LDL, or do you just start at a dose? Because apparently when you start at sort of a beginning dose, you get most bang for your buck, so to speak, with that low dose anyway. And then how do you escalate the dose when there's no history of, say, stenting or whatever? Because my understanding is that the evidence just shows that you get most out of it with that first, 20 milligrams if it's a torvastatin or whatever. Can you say more about that?
Exactly what you're saying. So statin evidence would show that some statin is better than no statin, and every dose increase you get a little bit less marginal benefit for that. So just being on a statin is probably most of your benefit right there. It doesn't really matter what the dose is. But also true for the LDL. So the lower the LDL, the more benefit you're getting. So that has been shown, but each point that you decrease the LDL is worth less of a reduction in your cardiovascular risk. So how do I actually start people on statin? I usually pick rosuvastatin 10 or rosuvastatin 20 or torvastatin 20 or 40. I just pick one of them, sort of arbitrarily look at the LDL. If people tolerate it very well and they're not at the target, I'll increase the dose. I don't usually go beyond rosuvastatin 20 or torvastatin 40 in someone who hasn't had vascular disease before. So absolutely true. Being on a statin, you're getting most of the bang for your buck right there just by starting it. But if somebody's not having side effects, try to bring their LDL a little bit down further. It's still 1 pill once a day. And so I would suggest keeping on going.
Thank you.
I hope I got the important things that people were concerned about. I will make sure that I realize now that my email address is not on this presentation, but I'll make sure that it's there. So if you have any questions at a later date as well, you can look at my email address. I'm always happy to answer questions that way.
Thank you, Dr. Sidhu, for that presentation. I see no further chats in the chat box. I think you covered all the questions as they came up, so that was great. And if anybody does have any questions as we're sort of finishing off, please feel free to unmute. And then just for information, I think that your slides will be posted to the website. So I'm not sure if everybody's familiar with that website that is available, and that if you would like a certificate of attendance, then you can go ahead and complete that online, and then that will be given to you. And then just to finish off today's session, again, if there's no questions, so this will be our last presentation till the end of August. So if anybody does have any sort of topics that they would like covered, the website does have contact information for Dr. Thompson. I believe it's Ben Thompson, and you could email him on the website, and then that way, if you have any kind of specific education you would like presented, then they can seek that out for you and present. Yes.
Craig, it's Marilyn again. I feel like I'm always the one blabbing away questions, but if there's no one else that has a question, Dr. Sidhu, I was somewhat chastened and sobered by your point that you rarely use any insulin beyond like a basal insulin at night. So many of our patients, or at least I should maybe say patients that I interact with, their A1Cs are like 10, 11, 12, like just in the stratosphere, and you end up going with these, Humalog with meals, and that it's going to increase weight. That's why it's been great to have newer agents. And this has just been a fantastic, really crisp presentation to guide some of those choices. But in terms of insulin, I mean, I don't know. I feel like sort of somewhat out of desperation, what sounds like an awful word, I've add Humalog with meal times and so on. So it sounds like you're really cautioning that because of obviously that the increased resistance, I guess, with weight. And so we should really maybe back off on the, meal insulin or Humalog and add these other, aggressively add these other agents. It sounds like what you're saying. So that's the first kind of question point. The second is, I was interested that you said, and I have to go back, that there is good evidence that using the basal agents you suggested are better than, for example, using like Lantus. So can you just quickly comment about that?
Yeah, so I'll just do those in order. So those are excellent questions. So the rapid-acting insulin, now the one that really changed whether people need insulin is the Ozempic, the GLP-1 receptor agonist, because you can now get 2%, 2.5% off just with that one. And so that's the one that really changed whether you need insulin or not, and it's really good for after meals. Still, if we really aggressively titrate the basal insulin and you look at the A1C, you might get away with no rapid insulin with the GLP-1, the basal insulin with that sort of approach. Still, there's lots of people who do actually need the bolus insulin, and it does happen. I just want to caution, just exactly what you're saying. I just want to caution that we really don't need to jump to it as much as we used to. And people are very happy that we don't have to jump to it because they might know a lot of people who are on multiple daily injections of insulin. So if I'm starting a rapid insulin, I'll usually actually only start it once a day. So that's when I get them to do a glucose log. and I say, well, look, your dinner time's really when you're jumping the most. We're just going to do rapid at dinner. So I'm really trying to limit the injection burden as much as I can. So we use the basal, and then if I still need something, I don't do the rapid with every meal. I just find their biggest meal and go for that. And then I reassess. And if it's now I need it for a second meal, I will. I've got lots of people who are on 4 times a day. It's just, I think, a little bit less common. Then your second question was about hypoglycemia with the newer insulins. And there's a little bit, the data originally is about variability. So if somebody goes to bed with a sugar of 9 and they wake up with a sugar of 6 and they use Lantus overnight, it turns out that 6 is really 4.5 to 7.5. So there's a wide spread in the sort of absorption and action of that Lantus. And Tresiba and Toujeo have shown that they get less. It's much narrower, and their 6 is actually 5.5 to 6.5. So they're less likely to go low. And they actually did the trials head-to-head with Tresiba versus Lantus and Tresiba and Toujeo versus Lantus. And now they've actually done Tresiba versus Toujeo. And they've shown less hypoglycemia with the 2 newer insulins than with the old one. I won't tell you about the Tresiba versus Toujeo, which one's better, because Tresiba showed that they were better and Toujeo showed that they were better. So I actually don't know if there's one that's better than the other, to be honest. So, but there is evidence to show less hypoglycemia, and especially overnight hypoglycemia while you're titrating the insulin if you use the 2 newer ones.
Okay, great. Thank you so much. Do you ever start people on insulin and then stop it? So they present, sugars of 20 or 30. They've never, this is their first presentation. This is super common. There's an incidental finding of a sugar of 35. So
I do.
Go ahead.
I suggest that. I suggest actually starting insulin in those situations. It turns out that the medications, the oral medications, a lot of them are susceptible to something called glucose toxicity. They don't work very well if the sugars have been high for a long time. So this is the phenomenon of the only thing that can get your sugars down is insulin, but all the other medications can keep your sugars down. So we need insulin to get you to where you need to go, and then we add in the other things, and then we can take off the insulin. You'll be fine. So that is definitely a thing.
Great, excellent. That is so excellent. You're clarifying that. Thank you.
Dr. Sidhu, can you give us your website again, please?
The website for the slides is in the chat box. And then what I'm going to do is I'm going to type in my email address here as well. If anybody wants to send me an email at any point, that's there. You can also find me on eConsult. If anybody's set up for that, you can actually just select and ask a question.
This one?
This is his name.
Yeah.
So if there's nothing else, thank you very much, everyone, for having me. And I'm always happy to talk about anything endocrine related if that turns out to be a topic next year as well.
Excellent. Thank you, Dr. Sidhu, for your time this morning. And with that, we will close our session this morning, and it will be recorded for you on the website that was listed in the chat box, as well as some other information. So please reach out to any of your practice consultants, myself, or any of the other team if there is any questions or any topics, or Dr. Thompson that's noted on there. And with that, have a great summer to everybody, and we'll reconnect back in end of August.
Thank you so much.
Thank you.
Thank you all. Have a great day.
Yeah, thank you.
Thank
So
you.
presentation in service is closed after the end of August.